Hey, welcome to part 3 of our discussion of schizophrenia and affective disorders. This time we're moving on to our discussion of affective disorders. So, major affective disorders are serious mood disorders that are characterized by disordered feelings. The most common one that you've probably heard of is major depressive disorder, often called depression. This is characterized by unremitting depression or periods of depression, so it's sort of a down mood state. And we'll talk about the criteria for diagnosing major depression in just a moment. Bipolar disorder is similar to major depressive disorder, except it is characterized by cyclical periods of mania, which is a high energy manic state, and depression, which is very similar to major depressive disorder. These affective disorders seem to be highly heritable, showing a concordance rate as high as 69% in monozygotic twins compared to 13% in dizygotic, suggesting a very, very strong genetic component to affective disorders. So, how do we diagnose major depressive disorder? Well, if you're seeing a therapist and you're concerned that you might have major depressive disorder, you'll be asked a lot of questions, and the therapist will sort of compare your symptomology to a standardized list. The sort of standardized list is found in a basically a manual called the Diagnostic and Statistical Manual of Mental Disorders, or the DSM for short. We're on the 5th edition, so it's the DSM-5. This is basically a list of diagnostic criteria. The DSM-5 exists to help clinicians make sure that they're all speaking the same language, so to speak. So basically, it guarantees that one therapist's diagnosis of depression isn't completely different from somebody else's, right? You can imagine that a therapist operating in China, for instance, might have a lot of a different idea about what depression is than somebody working in a rural town in America. The DSM-5 is meant to standardize diagnostic criteria across the board. This does a couple of things, right? One, it lets us have a common language for the study of mental health disorders. So we know that when we are categorizing people as, let's say, depressed, we know we're all using the same language to do that. And that way, when we try various outcomes, be those therapies or pharmacological interventions, we know that we're applying them to a similar population of people. On the other end of that, this allows clinicians to take that knowledge and apply it, right? You know that if somebody meets the criteria for a mood disorder like depression, you know they are probably at least somewhat similar to other people who meet it, and that there is a course of treatment that you might pursue recommended by the DSM-5. So that's why we have it, right? It's kind of a controversial thing. Some people think that adding labels to people is inherently marginalizing, and it certainly can be, but the DSM-5 seems to convey more benefits than it does harm. An unfortunately really important thing about the DSM-5 is it's also how medical practitioners formally write down on your chart what it is that you have, which is really important for insurance purposes, right? So if you want to get treated for a mental health disorder, being diagnosed with something allows your insurance to pay for that, which kind of sucks and is an issue with the medical model in general, which we won't super get into right now, but that's another purpose that it serves. Anyway, looking at diagnosing major depressive disorder, those with MDD suffer from at least one of the following: depressed mood for most of the day and diminished interest or pleasure in activities, and then 3 or more of this list. Things like decrease in appetite or weight, insomnia, sleeping too much or disrupted sleep, lethargy, loss of energy, etc. 3 or more of these. And this can be a graded thing, right? You could have mild, moderate, or severe depression depending on how many of these boxes you check. It's important to note that major depressive disorder is more than just a depressive reaction, right? It's normal to have a depressive reaction in the face of an upsetting event. Normal people will feel down after divorce, death, financial loss, etc. If you came home when your house was burned down, you would probably be really bummed out for a while. That doesn't mean that you're depressed necessarily. It means that you're having a depressive reaction, which is healthy and normal, right? This gives us a chance to slow down and make sense of what's happening, right? Deal with our trauma when it happens. And in fact, slowing down can be adaptive in short bursts. It's not always best just to power on through disaster. That said, when it becomes dysfunctional and disruptive and causes you distress, that's when we would call it a disorder. With many things within psychology, things only become a disorder when they cause you dysfunction or distress. People with major depressive disorder are often poorly understood or blamed for their state, right? So you might see someone who's depressed and hear people say that they ought to pick themselves up and get going or stop being so sad all the time. But that's kind of a misconception, right? Mental health is a real thing that we need to really care about. You wouldn't blame someone for having an asthma attack, so why blame them for their depression? It's unfortunate that so many people attach a stigma to mental health because it is really, really important. So depression is extremely common. It's the number one reason why people seek mental health services. About 6% of men and 9% of women will experience depression in a given year, and 12% of Canadians and 17% of Americans experience depression over the course of their lifetime. So almost everyone listening to me right now either has had depression, will have it, or knows somebody that does, because it's extremely common. Sometimes people call this the common cold disorders, not because it's not severe, but because it's extremely pervasive. And it may not be, it's not quite as obvious as a cold is. It's also far longer lasting and harder to treat. It's something very serious that should be taken seriously. So bipolar disorder is somewhat similar to major depressive disorder. So with depression, we have feelings of unworthiness and guilt, little energy, anhedonia, which is the lack of pleasure taken in previously pleasurable activities, and disturbed sleep. This can be either hypersomnia or insomnia, right? Sleeping too much or not sleeping enough. People with bipolar disorder also exhibit periods of mania, which is an upstate, right? If depression's a downstate, mania is an upstate. This is a sense of unprovoked euphoria. They feel great. Non-stop speech and motor activity, so they're talking a mile a minute and moving around a lot, frequently changing from topic to topic while they're speaking. This can be accompanied with delusions, especially delusions of grandeur, that they're really onto something or they're doing something great, and they may go long periods without sleep. This alternates with periods of depression. Okay, that's it for our little introduction to affective disorders. Next, we're going to talk a bit more about affective disorder treatment.